Hi, I'm Dr. Jane. I'm a naturopathic doctor and a natural fertility expert. And this is the Natural Fertility with Dr. Jane podcast, where we help uncover the real reasons behind your fertility struggles. And in today's podcast episode, I want to walk you through exactly what to test the moment you get a positive pregnancy test, but also what you need to do throughout pregnancy to make sure that you're well taken care of. A positive test is not a finish line. Let's be honest. It's just the beginning. And for most women, they're just either told to test their HCG a couple of times and confirm that the pregnancy is good and then wait until the ultrasound to see if it's actually viable. And I don't think that's very good advice. I think there's so much that we can do, and there's so much that we do in our practice for our patients to help support them through that first trimester of pregnancy when the anxiety can be really high, but also what we do each trimester to make sure that the woman has everything that she needs from the nutrient perspective, but also mental, emotional, and spiritual health to bring this baby earthside. So let's go into it. And there's a couple things that I want you to keep in mind as we go. The number one thing is that your HCG number by itself is usually not enough information. The second thing is waiting until the ultrasound to see if the pregnancy is viable, I think is very bad advice. And there's so much that we could be doing to actually influence the pregnancy and see if we can keep it if that's in the cards or not based on testing, instead of just waiting and seeing what happens. The third thing is, if you've been struggling to conceive and then you become pregnant, I genuinely think that you need a higher level of care and attention. Now, I think everybody needs a high level of care and attention, but we tend to just say, well, if someone got pregnant easily, then we assume that the pregnancy is good and the postpartum period is good, and it's all based on assumptions. I was that person that went into pregnancy blindly. I didn't have any issues conceiving. My pregnancy was not easy for me. It rocked me. My postpartum period was not easy for me. It was very difficult, and it impacted my relationship with my daughter that I'm still working through. So I think it's very, I don't want to say arrogant, but it's just like overseeing it to say, oh, once you get pregnant, then it's good. The body will figure it out. And if you've been struggling to conceive, chances are there's been some mitochondrial issues, there's some immune stuff, there's some inflammation, there's blood sugar. And even though we've corrected it or have tried to correct it, your weakest link will show up during pregnancy. So I think it's really, really important to support our women through pregnancy and our couples to make sure that we decrease the number of the complications and emergency types events that happen at the end of pregnancy, when we can actually see those events coming a mile away. For example, when women ask me, what do I do to prevent preeclampsia? Well, preeclampsia actually starts to develop with the formation of the placenta. And that actually happens in the first trimester. So understanding those things and understanding the history and all of those components is really, really valuable. The last thing that I'll say, a positive test doesn't mean that anxiety stops. And I see so many women actually get way more anxious once they get a positive pregnancy test, because now they're so worried about losing the baby. They're so worried about doing anything wrong. They don't trust their body because they never trusted their body. They're overthinking everything, and they don't have the right of team to support them. So I think that there's so much that we can do for women to help them support that anxiety and hopefully deal with some of it beforehand, so then she can go into a pregnancy feeling more empowered and joyful and peaceful and all those beautiful feelings that she was hoping to feel, instead of really anxious. So let's jump into it. And before we go into all the testing that I want you to do the moment you get pregnant to the first trimester, second trimester, third trimester, what I will say is, in my practice, we know our patients really well. So ideally, I want you to have a really good lab work right before you are starting to try to conceive. And in my practice, we give couples 3 to 4 months to try. And then if they don't conceive, we're generally already thinking about some kind of testing or something to make sure that we're not, prolonging their journey, but we're also addressing the issue that's preventing them from being able to get pregnant. So ideally, right before you conceive, you have a good blood work done. So we know where your inflammation is at, what your blood sugar is doing, your thyroid, your progesterone, your inflammation. We don't want surprises during pregnancy, or as little surprises as possible, if you will. And we just want to know what we're walking into. And ideally, we know your history, both your man from, your partner and yourself, because it will give us an idea of what is the moment you get pregnant. There's some testing that we want to do. And then we want to do testing as the pregnancy is progressing. And I'm going to dive into all of that. But the last thing is I want you to have a team of practitioners. So often when we are working with our patients with complex fertility issues, they have multiple practitioners. And whether that's a NAPRO specialist or they have an OB or they have a PCP, we usually need a team of practitioners to support us. And that could be acupuncturist or physio or a chiro or something, massage therapist. And then when you're pregnant, you also need that team. And whether you choose to go with like a midwife and a doula or an OB or it's, your fertility clinic, you need someone who's going to look over at the case. And I really want to set a new standard in healthcare in general, in fertility care and in pregnancy care, because I see so many women that are not tested properly at all. And then we see big issues in the third trimester or in the second, or we see unnecessary losses, and it's heartbreaking. So my hope is as I go through this, you kind of start to understand and you start to find your person. So for many of our patients, we are the people that they go to as their, natural fertility specialist and natural pregnancy specialist. But we also lean on whether it's midwife or OB or anyone else to support us with things that we cannot do online. So the moment you get that positive pregnancy test, we tend to test a HCG. We want a quantitative. We want to see the actual number. And we do a progesterone, and then we repeat the HCG 48 to 72 hours, and we're looking for it to approximately double. Now, the progesterone levels are really important, and the HCG levels on its own doesn't tell us much. Sometimes we'll look at one number and it looks really low and we're a bit worried. But what we're looking for is that quantitative. Is it doubling? Is it tripling? How much time has passed? So usually we can connect, HCG can be detected within 8 to 10 days post for ovulation, and then it should be doubling every 2 days for a viable pregnancy. That's a good sign, okay? Usually, if you have really high HCG, there's also some things that we're looking for, whether it's a twin pregnancy or a molar pregnancy, but again, on its own is not enough. For progesterone, we have targets that as practitioners we look for that are slightly different than the conventional. So the conventional will say anything above 10, that's good. To us, over 10 nanograms per mil is very, very low. And that's somebody that I think we did not address progesterone levels properly. I want them at least above 15 to 20, but ideally within 20 to 30 range. And progesterone is not going to rise a lot in that first trimester, but it should be hovering in the 30s in the 20 to 30s when we first test. And then if we decide to retest, if we're not sure if those levels are low and we need to actually supplement that progesterone, I want to make sure that progesterone gets to the optimal level, because progesterone is so important for implantation, it's so important for neurological development, and it's so important for your anxiety. When women have anxiety, they tend to have those lower levels of progesterone. And so I can see it and feel it in her. And if we tested, we see that progesterone is low. So when we bring the progesterone up, she tends to feel much, much better and doesn't overthink as many things. And then, of course, that's much better for her immune system and for the baby's development. So that's like, you just found out you're pregnant, test the HCG, look at the progesterone, look at the HCG again 72 hours. Depending on where your progesterone is, you might need to test it more frequently to make sure that you get the right levels of it. So do you need vaginal, do you need an injection? Do you need oral? Ideally, you have your progesterone levels figured out and we have that good blood work before you're getting into pregnancy. So this period doesn't become stressful. And I've had numerous clients where we've gotten pregnant and we relied on the OB to test and then to give us progesterone in case she needed it. And she did need it, and the OB didn't want to because in her eyes, it wasn't low enough. And so that becomes a very stressful situation. So I tend to, or they give you a progesterone that doesn't work and then they don't really want to retest it. You want to understand those things, ideally, before you're getting into it so we don't add any unnecessary stress during this time. And I had a patient with thyroid, that was the same thing. Her TSH was so high. It was at like 4 or 5. And the doctors would just like refuse to test and refuse to prescribe. And they're like, thyroid doesn't really matter this early in pregnancy. And it was like, this is before AI. I'm like, I'm just going to smack my head against the wall here talking to these professionals who are telling me that thyroid function is not necessary during pregnancy, early pregnancy. It's just the most insane thing I've ever heard. So, and progesterone, please do not get off it until you have confirmed that the levels are where you need them to be. And we have certain standards that we're looking in the second and the third trimester in terms of that progesterone levels. So then we're not pulling our women off progesterone before the placenta has taken over. And sometimes it's like week 16 and even week 20 that we're going to pull the progesterone off, while other women can get pulled off at like week 12. So do not automatically just pull yourself off because that trimester is over now. You want to measure it with data and make sure that you're not pulling, the rug from underneath your body. And like I said, there is the vaginal, there is the oral, and then there is the injections and even patches. So there's different types. We want to figure those things out. So that's as soon as you get pregnant, and then you might need to get more testing done depending on what that HCG and the progesterone was to get those numbers right. Not the HCG. HCG is either going to rise or it's not. Progesterone, we want to make sure we get that number right. I don't tend to retest a bunch in those first early weeks because it just feeds into anxiety. And then you're constantly are like worried, and it just adds into the drama, if you will, of it all versus just letting the body do what it needs to do and resting as much as possible. I do like to do first trimester blood work, and that usually falls anywhere, I would say, between week 9 to 11. And it will fall if you're doing the non-invasive prenatal screening. We can kind of time it at the same time. And this is my standard. I'll run that first trimester, second trimester, third trimester. Those are my minimums. And then if we have anything that's quote unquote wrong, whether that's progesterone we're tracking or iron or inflammation or blood sugar, I'll tend to retest a little bit more frequently and look at those things. So you want to look at the thyroid, you want to look at the iron, the B12, the vitamin D, the homocysteine. I look at zinc and copper. I look at inflammation levels. I look at blood sugar. I look at cholesterol. I look at progesterone. I look at the urinalysis, and I just kind of want to see how the body is settling into the pregnancy. And there's things that are going to be normal for pregnancy, even though they're not normal on the marker. This is how we know the reference ranges only apply to a certain population. And then, of course, there's things that are out of normal, and it is not normal to see in pregnancy. And so obviously working with a practitioner who's going to help you interpret that is really important. The ultrasound, the dating one, is usually week 7 to 9. If you're going to opt in to do that, some women don't want to do any ultrasounds at all. Some want to do the bare minimum. I think there's pros and cons to both. We do want to remember that ultrasounds are radiation. Some women are comfortable with that, some are not. And again, pros and cons to each. But the dating ultrasound, we're confirming the location, the heartbeat. You're looking at the CRL, the crown and rump length, the heart rate, the yolk sac, the gestational sac, if there is any hematomas. And you usually can see the early placenta and tissue development. If there's any uterine structures and issues like abnormalities, whether it's fibroids, et cetera, you want to be able to see those things. Then there is the non-invasive prenatal screening, again, usually weeks 10 to 12. Not everybody does it, but if you are going to opt into it, there's a blood work and there is an ultrasound that's done with it. So you see that that first trimester is pretty loaded in terms of testing. And then typically you're also trying to find a midwife, or you have an OB, or, and you have those appointments as well. And I'll talk about what they should be tracking and measuring on those. Typically, we get through this first trimester and then we go into more of a regular cadence. The second trimester blood work, I'll do anywhere between week 16 to 18. And then sometimes I'll do it at the end of the second trimester, so closer to week like 25 to 27. There's a really big methylation demand around week 16 to 25. So sometimes I want to see what the state that the woman is coming into, going into that big growth state, or I want to see how she's coming out of that later. And again, when we as practitioners know our patients really well, and we kind of know where some of their methylations genetics are, and nutrient levels are at, we can support them, and then we can see them with no symptoms. So whether it's every month or every couple of weeks that we're checking in with our patients, we can see, how things are progressing. So in that second week trimester, it's basically the same things. There's some stuff that I will take out or add in depending on what's going on with the patients. But I will start looking at things like bile acids, because we want to make sure, cholestasis, if there's anything that's going to be with the gallbladder or the liver or those early signs of preeclampsia, we can see them early on. And I always look for urinalysis. And I can't tell you how many women are walking around with urinary tract infections with no symptoms except fatigue. And so when you have fatigue, that's the most common symptom of a UTI in pregnancy. They won't get a burning sensation or frequency of urination. It will just be that the woman is tired. So the methylation window is week 16 to 27. It's high demand. So this is when we are looking at homocysteine and B12 and folate and also protein needs and omega-3 needs. There's just a lot that's going on. And when I talk about like my pregnancy, my first one that didn't go as well, when I think back, I had a lot of cold sores like almost every month, but it was actually the most around this period. And one of those as practitioners, I wish what I knew back then so I could have supported myself. I didn't obviously realize that was the case, but there was just inflammation and there was things that are happening that influenced my immune system and the adrenals and everything else that was involved. Then we do a morphology and anatomy scan. That's about week 19 to 20, and that's pretty standard. I have a patient who currently was like, they just do an ultrasound every 4 weeks. That is standard in their practice. And I just want you guys to know that's not standard. So if you are one of those people who is concerned about radiation and the ultrasound, or you're not even really aware, you just think like, it's an extra ultrasound. I get to see my baby. That's so great. Just do know that there is, like, we're testing, there's heat, there's some radiation, most women will get tired and they need to do some electrolytes and some grounding and those kinds of things after those events. So I'm a big proponent of making sure you have all the information and then you get to decide what you're comfortable with. And then there's also times and situations, one of my patients right now, she is developing preeclampsia and she's very coming up to the end of her pregnancy, week 36. Well, it doesn't matter if she doesn't want to get an ultrasound or not. There's times where it's just going to be important to do it because the pros outweigh the cons. So again, it's just having that full informed consent and then making sure you know what are the pros and the cons if I deny this procedure versus I have it. And every woman is going to be very, very different. During the morphology, like the anatomy scan, if you will, one of the things that's important to look at is the cervical length, because we want, cervix that's not shortening. If that cervix is shortening, whether that's progesterone, and the woman now needs to be on progesterone and vaginal progesterone throughout the whole, the rest of the pregnancy, or bed rest, or more nutrients, whatever it is. What's the placenta position? Where is it hanging out? The placenta is developing. Do we need some more blood flow things? What is it that when we match it with the week 19 to 20 plus the blood work, then we can really see what the body needs. And then we get into into third trimester, and you're essentially are just making sure that the body is handling the pregnancy well. So I've had patients who needed iron from the moment they got pregnant, and then I have patients who didn't need iron until the third trimester. That's something that we want to look for. We want to make sure that the thyroid has the support that it needs throughout the entire pregnancy, but the first 24 weeks are really, really demanding on the thyroid because the bub is using mom's thyroid hormone. So if the mom's hormones is sluggish and then the baby is going to steal it, she's not going to have anything left. And then the risk of postpartum depression and all the hair falling out and all sorts of things is much, much higher. So that's typically the schedule, if you will, for blood work. What I will say, a little bit of extra stuff that we'll do is I always recommend seeing a pelvic floor physio, usually week 20 to 24. Ideally, you would get your pelvic floor assessed before you get pregnant. Because for some women, the tightness in the pelvic floor prevents blood flow and causes constipation and all sorts of things that we need to work through that pelvic floor, or even painful cycles, to help everything integrate in from the diet, the lifestyle, and the supplements a little bit better. But you definitely want to have an awareness of your pelvic floor before you go into labor, because that was, again, part of my story where I just had no idea how to work my pelvic floor. And by the time, you don't want to find that out during labor. And so I needed forceps. I was one push away from emergency C-section. Like, it was, it was much more stressful than it needed to be. And if somebody told me to go and see a pelvic floor specialist when I was pregnant, I think I could have had a very, very different experience. And again, we just learn and share the information that we learn from. So in terms of, that's what I recommend, and that's in terms of what we do and what we recommend with your OB or your midwife. The standard OB visits is usually monthly, so week 0 to 20. So week 5, you typically find out. To 20, you're just seeing them monthly. And then weeks 20 to 32, you go to every 2 weeks. And then week 32 on, you go on weekly. What should be measured is your blood pressure should be measured, and then they usually listen to the fetal heart rate, and then they do usually test the uterus as well and the size, so we know that the baby is growing. Those are just standard things. And sometimes one of my patients who's developing this preeclampsia, she started to have some random high blood pressure issues very early on. And we kind of picked it on as anxiety. And it was because she would only get it when she was in office. And so we had her get a monitor at home. And when she was monitoring at home, things were good. And then there was times where it would climb up a little and then drop up a little and then drop down. And then now she's at 36 weeks and she did need to be put on medication to just control that blood pressure because it was a little bit, dysregulated. We could see it and monitor it, so there was no surprises. If we don't have those things measured and we don't know what's going on, then we can get ourselves into very emergency, stressful type situations that I think can be prevented. And this is what I'm saying about it could be prevented. It's not that preeclampsia was prevented from this patient, but how we're handling it is much better than her finding out by passing out or having dizziness or having to go, there's a lot of quote unquote scary things that can happen. So we want to be very careful and aware. And the rule for data for me is I know that data can make people anxious. It's really important that we have the data because the data gives us information, but you don't have to be the one interpreting it. If you're the one interpreting it, that's when the anxiety just skyrockets. But if I get you to have someone else interpret it and you're just collecting the information, then it kind of takes away that stress. And so I make sure, we at the clinic make sure we just tell our patients that we want the data so we can keep an eye on you, but you just plug it into our system and then we'll let you know when it's time to act. And most women know, my women know when it's something feels off. This doesn't feel right. So then we can do some further investigation. And, one of my patients, she was in Canada and I was it's so hard to get blood work to her. Maybe we shouldn't run it in that 3rd trimester. Everything has been so great in that 1st and 2nd trimester. She was sick and she had some whatever, but there was no symptoms and she had a really good pregnancy. And I was just let's just run that 3rd trimester blood work. And turns out she had extremely elevated liver enzymes and she ended up developing HELLP syndrome. And, thank God we looked at those liver enzymes because as soon as we saw them, I'm like, go to your OB, get them to retest it because nobody was testing her. It's oh, she has no symptoms. That's great. We don't need to test. And it's so backwards for me because by the time these symptoms develop, they're so dangerous by the time they develop for most people that it's no, we want to understand what's happening beforehand. Anyways, we ended up catching it really early. Her doctors, jumped on it, retested, and, obviously we got the baby here safe and everything was good. But sometimes we have these decisions that we're faced with and we're I don't know if I should run this test. And through the longer that I practice, the more I'm yeah, just run the test, even if it's difficult, because the information will tell us. And you never know when that information is going to be life-changing. And so my hope is, you having this idea of okay, when I'm pregnant, here's the kind of care that I want, and this is what I should be looking for. Sometimes shifting your focus from what do I do to get pregnant to how do I want to support myself when I am pregnant? You're almost you're almost training for the next thing, and you don't hyperfixate on the infertility so much that it actually helps you along in your fertility journey. And we as a practice always think about our patients like that. That's when I'm doing our intake and I'm how are you going to handle this anxiety when you're pregnant? If you're super anxious about every little thing, now I can sympathize with that. I have so much compassion. Let's figure that out. But it worries me from the pregnancy standpoint because pregnancy tends to heighten those things. So we want to deal with that now, so then we can prepare ourselves for pregnancy and then make sure that you actually have the right support going through it. So if this resonates for you and you're looking for someone who's going to specialize in both fertility and pregnancy, please fill out an application down below. My team will get back to you if we can help you. And if we can't, we'll still make sure to point you in the right direction so you still know what your next right step is. Otherwise, I hope you guys found this information super helpful. I appreciate you tuning in to another episode. If you have 2 minutes and you can rate the episode, that would be super helpful, or send it to somebody who you think is going to find it helpful. All of those little likes, shares are super helpful in getting the podcast out. So thank you so much for being here, and I'll see you next week.